Today, we're going to discuss a very important branch of forensic medicine, which is forensic psychiatry. As we all know, forensic medicine is dealing with the medical jurisprudence out there. So basically, we are looking at the legal aspects of whatever case we are dealing with. Obviously, these are the medical cases that we're dealing with, and this branch, which is the forensic psychiatry, it's basically dealing with the psychiatry of the individuals who have some sort of a criminal aspect in their thinking, in their behavior, and in overall management of things out there. So basically, usually you would be required to assess, or you'd be required to examine these individuals and have the mental state examinations of these individuals documented and obviously put on for further examination. Now, it's again very important that you carry out this examination in a very particular manner. There are some aspects that you have to consider that have their own significances. The interview is usually carried out in an examination cell, and usually you'd be required to carry out these interviews with the suspects of some sort of a criminal activity. It can be stealing, it can be murders. You might be dealing with people who have committed homicides, or even people who have committed suicides or have attempted to commit suicides in particular. So it's again very important to analyze their thinking process, how they think, how they analyze things. And obviously, there is a very thin line between the organic disorders, which can manifest as the psychiatric delusions, psychiatric hallucinations, and obviously to distinguish whether there is some sort of an organic disorder or this particular person whom you're interviewing is suffering from some sort of a psychiatric illness. Again, doing your homework is very important. Whenever you have to interview these suspects or these criminals in the cell, you must do your homework. You must get the corroborative history from the people who are taking care of that particular patient, of that particular criminal. They would give you that particular history. That is basically pointing out towards their abnormal behavior or their abnormal delusions, or it may even be the hallucinations that these criminals are suffering from. Again, it's very important to distinguish between the criminals and the suspects on the other hand. Sometimes there is a lot of confusion. There is a distinguished diagnosis that is coupled up with a particular suspect. And when you investigate these cases, there would be a final result that you would come up to, that these patients are actually suffering from some sort of organic disorder that is manifesting itself in the psychiatric illnesses. So whenever the patient or the person whom you're going to interview enters the room, the first impression is where you're going to start off the documentation from. The appearance, the overall appearance of the individual is very important over here. Is he disheveled? Is he or she showing the signs of self-neglect that are basically pointing out towards the depressive episodes that the patient might be having? So this is very important that you focus on the overall appearance of this particular individual whom you're going to interview. Now, moving on further on, obviously, you're going to focus on the other aspects of psychiatry. Again, the examination, the inspection of the patient is very important. The overall behavior, is he agitated? Is he or she in a state of turmoil? Is he or she basically apprehended? All of these are going to be documented when you're going to write down the overall behavior. Again, you're going to introduce yourself. This is very important. The safety of the doctor who's interviewing is again very important, and the right of the detainees' confidentiality is again very important. So, if you're trying to interview a patient who has been aggressive in the recent past, you have to be very careful. You always request for some custodian to be present out there when you are carrying out the interview with the particular person. Because an aggressive behavior, a manic patient, that can basically cause a lot of harm to the doctor himself. So it's very important to maintain your safety as well and maintain the overall confidentiality of the patient as well over here. Moving on, obviously, when you would start off your interview by introducing yourself and describing the purpose of the interview in detail is again very important over here. You're going to explain everything to the detainee or to the person whom you're interviewing, that what is the exact purpose of this interview that you're conducting. According to the reports and according to the researches, there had been a lot of suicidal attempts that were carried out by the detainees when they were put into cells. Because obviously the environment over there is quite depressive for the detainee out there. And there have been reported reduction in all of these suicidal attempts and in all of these cases that are reported with suicides when the people are put to the cell. So it's again very important that why is this happening? Because of the psychiatric evaluation that is done nowadays, and it's basically being a very important part of forensic investigations. And as a forensic practitioner, you'd be asked to do all of these interviews with the people who are put to the cell, and you're asked if this particular person has some sort of suicidal intentions or not. So this is again going to highlight the fact whether he or she has some suicidal thoughts or any signs of self-harm, self-destruction are present in this particular individual or not. With the start of the interview, you're going to continue this particular phase, and you're going to basically mold up and write down the positive findings in the motor activity of the individual as well. Now, there can be an increased motor activity of the individual. Flight of thoughts may be present. It can be the person might be suffering from some sort of auditory hallucinations that you might not be able to hear, but that is basically causing the distracted behavior of the detainee himself. So going to note down the overall behavior of the individual. Again, it's very important to focus on the fact that whenever you talk to that person, there are some traits that you're going to examine. It may not be any certain psychiatric illness, but there are basically some borderline personalities out there having the traits of OCD, that is the obsessive compulsive disorder, or type A personalities. You're going to basically document all this down and note down whether this particular person has some sort of disordered traits of psychiatry or not that he or she might be suffering from. Again, the content of the speech is very important. The form of speech is very important over here, whether the person has a fluent speech or is it the interrupted speech that you are listening to. So you're going to focus down and you're going to document each and everything that you hear. It can be some delusional thoughts. As I said, the content of speech is very important. So what kind of speech and what kind of thoughts that the person is having is very important over here. It can be that the person is suffering from delusions of grandiosity. So you're going to note that down. If the person is suffering from delusions of paranoia, that is very important. That there is some sort of a prosecution going on, and even the close relatives and friends would tell you about this, that the person has these delusions of paranoia, that he or she has been suffering from whatever time period, and you're going to specify even that over here. What caused these delusions, what caused these hallucinations is very important. Even the person can have delusions of guilt over here. It can be regarding any past event that took place, delusions of religious beliefs that are going to be noted down. So all of these are going to be documented when you are taking the history into account. Again, hallucinations are of different kinds. For instance, we have the visual hallucinations for a very less percentage of people, except for people who are suffering or who are diagnosed with schizophrenia. They only suffer from visual hallucinations, and even usually the kind of hallucinations that these people would be reporting, people suffering from schizophrenia, would be auditory hallucinations. It can be more than one hallucinations, it can be more than one voices that come to their mind and they have to interpret, and basically it's again very distracting, and even their speech would show that factor that they're distracted by those auditory hallucinations that they're listening to. Again, making a rapport with the patient is very important over here. The patients basically take some time to build up the rapport, and then only they would be directly answering your questions, whether they're hearing voices, whether they are seeing things, or whether they are seeing people around them that are there, that are basically not actually present out there. So telling this to another person and telling this to a doctor is sometimes more dependent on the fact that how much rapport you have developed with the patient. Even in the very first interview, the patient might not open up and come up with the problems that he or she is having. So you need to have more than one sessions with the patient, more than one interviews with the patient to develop that rapport and to have that confidence within your doctors, that so that you can basically convey your message, convey your problems regarding any thoughts, regarding any things that you see or anything that you hear which is not actually present over there. Again, you need to focus on any obsessive compulsive traits that the patient is having. And moving on, obviously, the levels of cognition. Again, how do you test for the levels of cognition? There are these simple tests that you carry out, and that would basically highlight the fact that what tests are you going to carry out in this particular case or in this particular patient. Moving on, the psychiatric roles of forensic practitioner. As I said, it's very important, and the reports and the researchers have basically concluded to the fact that to carry out an interview, a productive interview initially, when you put someone to the submission of a cell, it's again very important to analyze the tendency of suicidal attack or the tendency of homicidal attacks, what kind of a general behavior, what kind of a personality the person has. It's again very important over here. So as a forensic practitioner, you are sometimes subjected to these interviews, and you might be well versed with the psychiatric aspects of the crimes. To defend the person by this aspect is not your duty. Obviously, it is the duty of the legal officers, it is the duty of the lawyers to perform that. It's just that you write down the report, you write down your own opinion in detail, and that is what is counted over there. So the psychiatric roles of the forensic practitioner can be seen over here. We have the assessment under the relevant mental health legislations. As a forensic practitioner, you should be well versed with what medical or with what health legislations you're working with. Basically, the health legislations, they differ from country to country. So it's very important that you focus on these facts, that you just go through and you just have the complete knowledge regarding the health legislations of that particular country in which you're practicing. Because under those health legislations, you can even provide the correct treatment to the person who has committed a certain sort of a crime. And you should know basically the rights of the citizens as well. So it's again very important to evaluate the mental state of the particular crime that has been carried out, under what circumstances. So it's again very important over here to evaluate and to study properly, and as I already said, do your homework properly before you carry out these assessments, these mental state assessments in the cells. The diversion from criminal justice system is very important. Knowing the legal system to some extent is very important for a forensic practitioner. For instance, in a country that you're working, you should know the laws that you're working with, and what are the rights of the citizens of that country, and what are the mental health laws that are being applicable to that particular area in which you're working. So knowing the justice system accurately is very important over here. The impact of a detainee's mental illness on the fitness for the interview. It's again very important. If the person is highly disoriented, he's in a state of delirium, he's unconscious according to the GACS scales, how can you carry out a particular interview in that setting? So it's very important that whenever you have or whenever you get these patients, you carry out the complete general physical examination of the patient. That would include the vitals of the patient initially. The vitals would basically give you the facts regarding the physical state of the individual. Is he or she suffering from some sort of an illness? That is going to highlight these facts, and you're going to focus on these facts particularly over here. So it's again very important that you focus on these facts and you highlight these facts over here and write them down, that the interview was not possible due to so-and-so factor. You're going to highlight that down in your documentation. So this is how you basically carry out the procedure. The advice on need for an appropriate adult is very important, and then the risk of suicide or self-harm. So there are these particular points that you're going to highlight over here. Sometimes you would have these patients, and sometimes very evitable on their wrists or on their accessible parts. The highlights are the basically the tentative cuts and the hesitational cuts that are present. So what are the characteristics of the tentative and the hesitational cuts? They're usually multiple in number, and they're not that deep. They're usually multiple in number. They are on the accessible portions of the body. For instance, the wrists are the most accessible portions. So these are the signs of the self-harm, and they're basically indicating the suicidal intent or the suicidal thought that the patient might be having or might be suffering from. So whenever you look at the overall appearance or the overall behavior of the individual and you completely examine these patients, that would highlight these particular points, and you can directly write them down that this person is having some sort of a suicidal intention, and maybe that can save the life of a person. So it's very important that you note down and you analyze these patients in detail over here. Moving on, some common terminologies that once you're writing down or once you're documenting the history. Over here, when you're dealing with the psychiatric patients or when you're dealing with patients who are suffering from some sort of a psychiatric illness, who have committed some sort of a crime, may it be a homicide. As we all know, homicides are basically of three important types. We have murders, we have manslaughters, and then we have the defense sort of homicidal reactions. So that are basically the justifiable homicides. People who have committed justifiable homicides are not suffering from some sort of a psychiatric illness because that was committed in some sort of defense action that the person had, and that is basically justifiable. So we're just dealing with people who have committed murders or manslaughters, and you want to know what is the is there any sort of a psychological aspect to this crime that he or she has committed? This is very important. So whenever you are taking that history, it's again very important that you focus on these terminologies and use these terminologies accordingly, rather than even you can even write down the exact wordings of the patient, of course. That is again very helpful over there, because sometimes you might not be able to interpret the problem, but when you write down the exact wordings of the patient, the exact feeling of the patient, some other person or some other practitioner might be able to interpret those words in particular or in a different way. So it's again very important that you write down the history in words of the patient and then obviously interpret that history accordingly. For the interpretation, you would be needing all of these interesting and all of these very important and significant terminologies that I would be discussing over here. So comorbidity, the patient can suffer from comorbid conditions. Whenever we use the words, even in the other medical conditions, we're usually dealing with the other medical conditions that the patient might be suffering from. For instance, he or she might have some sort of an organic disorder, for instance, diabetes, hypertension. So if he or she is suffering from some sort of organic disease, he or she is a diagnosed case of hypertension, diabetes, or any sort of cancers, tumors, you can just mention that directly. But over here, focusing on the psychiatric aspect of forensic medicine, we should write down whether the patient has any other psychiatric comorbidity, which can be a diagnosed case or which you can diagnose on the spot. So it's again very important over here. Patients can suffer from depression. At the same time, they can suffer from obsessive compulsive disorders. So these are two distinct entities and these are two distinct diagnostic criteria over here. And a single person can suffer from both of them or even more than two diagnoses at a particular time. And you have to document these comorbid conditions over here. Sometimes when you're suffering from more than one or more than two psychiatric conditions at the same time, that is going to make the situation more worse and it is going to make the patient more aggressive in the overall behavior. So you're going to document the comorbid conditions that the patient is suffering from. Moreover, the patient can be in a state of delirium. Now, what is delirium? How do you define delirium? It's basically an organic altered level of consciousness that is usually marked by the increased activity of the individual. The patient would be suffering from hallucinations and he's basically in a state of mania. And obviously there is an altered level of consciousness in this particular patient. So this is when you say that the patient is in a state of delirium. It can be due to organic causes, it can be due to psychiatric causes. So whatever the case is, you have to basically notify that in particular over here. Moreover, the patient can be suffering from a state of depersonalization in which there is an altered level of reality. So I'm not real. These are the particular statements that the patient would be giving. He's basically having the feelings of altered reality around him. This is not real. I think that this is some sort of a dream that I'm in, and this is basic. These are the exact wordings of the patient when he's suffering from the state of depersonalization, or in which the reality is basically neglected over here. So even you can write down these statements if you're not remembering or if you're not recalling these terminologies on the spot, and then later on you can interpret regarding these particular statements and regarding these particular things that the patient is talking. Derealization is again the same phenomena in which the surroundings and the environments are in a state of altered reality to the patient, and the patient is usually suffering from these. Then the patient can have delusions, and delusions are quite subjective over here. But to define delusions, these are basically the false beliefs, strong false beliefs. These are the three words that is basically emphasizing on the fact of delusions over here. They are strong beliefs. They cannot be shattered when you say, no, it is not present over there. They cannot be shattered that easily. They have their own reasonings. So it's again very important to take the patient out of those delusional states. And again, these delusions are going to be against the intellectual as well as the social environment of the particular patient. So these are the particular definitions that you have to remember when you're going to say that the patient is suffering from delusions of paranoia or he has some religious delusions, obviously you have to basically figure out whether it is just a thinking process that can be shattered, or whether they are firm enough that they can be termed as delusions in this particular case that we're dealing with. Moreover, the patient can have dual diagnosis over here. So it can be even called the state of comorbidity, as we've already discussed, that the patient is suffering from any other illness over here. And again, the history is very important, that whether you are suffering from some sort of a substance misuse or not. So it's again that the thinking process can be altered due to a toxic effect, that some sort of a toxic effect or some sort of a drug that the patient has been taking. So drug intoxication is again very important over here, and you ask for the history in detail from the patient as well as from the relatives and from the friends that have been close to the patient, and they would basically highlight the facts over here. Flight of ideas is very important. Again, the speech is going to show the fact that there are any related ideas. The accelerated speech and the state of mania is going to highlight that over here. Moving on, we can have hallucinations even in these patients, and that are basically can be referring to the auditory, to the visual hallucinations, as well as to the tactile hallucinations. So these are the three kinds of hallucinations that the patient might be suffering from, and upon them, the most common are the are the auditory hallucinations, and then we have the tactile. These are the most common hallucinations that we usually deal with. Then we have the ideas of references. So the ideas of reference is basically when the patient is basically making a relation between a subject, between any object and any idea, or sometimes people are related to some ideas, and that is again a kind of a delusional state, a delusional collection that is present. It's actually not present over there, and the patient is having that state of reference or that ideas of reference with that. Again, these statements would highlight the fact over there, and you can easily diagnose that. Then we have the mental disorders, a diagnosed case of OCDs, a diagnosed case of depression, mania, bipolar disorders, schizophrenia. Obviously, all of these mental disorders can be present in a particular patient in a particular time over there. Then passivity, the social passivity is the highlight over here, and you're going to write down the fact whether the patient is in a state of not socially interacting with the other people around him, and that is basically going to highlight the passivity of the individual. Personality disorders, as we've already discussed, we can have the traits of obsessive compulsive disorders, then we have the type A, B, and C personalities. So whatever disorders that the patient can have. We have even the borderline personality disorders. That is basically a very thin line between the psychiatric disorders and a normal person. And you have to highlight the traits, the specific traits that you have found in a particular patient who are making them more prone to the development of a particular psychiatric illness over here. Psychopathic disorders are basically highlighted by the mania over here. The abnormally aggressive behavior or a highly irresponsible behavior is termed as a psychopathic disorder that we usually deal with in these patients. And then we can have a thought disorder in these patients as well. The thought form is very important. The thought content is very important over here. Sometimes the patient is uttering words and there is a word salad. So usually even you use this terminology of word salad for people who are just uttering words and that cannot be even comprehended. So this is even noted down. It can be due to even the flight of ideas that the patient is suffering from, and that is basically affecting the speech of the individual. The final outcome of the individual is basically affected over here. Moving on, we have the assessment of mental state. So having or running down the background information, getting your homework done, you must know what is the background of this particular patient that you're interviewing is very important over here. So you do a little research on this particular patient that you're interviewing, what kind of a crime he has been involved in, what were the circumstances out there, and that is going to clarify the picture in particular in this particular case or in this particular crime that you're dealing with. Whether it was a psychiatric disorder that basically intended that particular crime, or whether it was some sort of a defense kind of a murder, or that is again a justifiable murder in this particular case that you're dealing with. So the settings of the interview is again very important. When you conduct this assessment of the mental state for the individual, you must have that particular settings around you. The environment is very important. How you start off with the interview is very important over here. Introducing yourself completely is very important. And you move on to the purpose of examination over here. You explain completely to the patient so that he may feel safe and he may confide the particular problems that he or she might be facing. So this is very important over here. Then having a consistent style during the interview is very important. Do not put the closed-ended questions to the patient. It should be the open-ended questions, and you ask the patient to speak up and confide with you the specific feelings that he or she is having. So this is very important to have that particular rapport with the patient. Now, you as an examiner look for the overall appearance, and you'd be looking for all the aspects that we've already discussed. You'd be looking at the behavior, whether it is agitated, whether it is repulsive, whether it is aggressive. You would note down accordingly. Then the mood, is it elated? Is it normal? Or is it a depressive kind of a mood that the patient is having? Even that is going to affect the thought content of this particular patient. Then if he or she is having some sort of hallucinations, and as I've already discussed, the patient won't confide directly about the hallucinations or about the delusions that he or she might be having. So within one or within 2 sessions, he or she might confide with you these particular hallucinations that he or she might be having. The motor activity, the patient can have signs of Parkinsonism, tremors, and all of these are noted. Dyskinesias, these are going to be noted down in these individuals. Then the cognition, that is the thought content, thought form. Is he or she comprehending your commands or not? This is very important, and this is very significant over here. Obsessive compulsive traits are noted down in these individuals. Any false, rigid beliefs that the patient might be having. And then finally, any suicidal or homicidal thoughts that are coming up to his mind. That is going to, these are all going to be the questions regarding all of these things that you're going to put on, whether he has or she has some thoughts regarding the suicidal intentions or homicidal intentions or not. So you're going to even ask these questions in cases who have not committed very serious crimes, because sometimes people have intent towards these more serious crimes. So you would have to basically analyze patients accordingly. This is a particular kind of a scoring system that we usually follow when we interview these patients. This is known as the Folstein Mini-Mental Status Examination that you carry out. You give scores to these patients, and the scores awarded to these patients let you know the mental state of this particular patient. Sometimes it is a score of 5. This is basically an orientation, and how do you basically analyze this fact? You ask the patient that what is the particular date today. This is going to tell you about the orientation in time, space, person. This is very important. Then a 3 score is given for the registration. How do you analyze this registration aspect? The particular exam for this would be, you ask the patient that you listen carefully to me. I'm going to say 3 words, and you're going to say them back to me. So are you ready? You ask the patient to get ready, and then you utter those 3 words very slowly and with a pause. For instance, you're uttering apple, then you give a pause. You're uttering penny, you give a pause. Then you say the third word, that is the table, and then you give a pause. So you uttered those three words and you ask the patient to repeat those words to you. This is how you basically analyze the registration quality of the patient. Now, if they repeat those words back to me and you basically ask the patient to repeat them 5 times for you. So you scored the patient on the very first time, but still you ask them to repeat that 5 times for you. 2 is the score which is given for language, and you can even ask, what is this? You can show him a pencil or a paper or a pen, and you ask the patient to recognize the structure that you are telling him. 3 is for basically you ask him to read. Please read this and do what it says. So you ask the patient to read and comprehend. The idea of comprehension after reading is tested over here. It can be close your eyes. So you have written this on a piece of paper, close your eyes, and you ask him to act upon that command. This is how you score for this. So the total score for this mini mental state examination, these are small tests that would even not even take 5 minutes to complete this Folstein Mini-Mental State Examination for these patients. And it is basically giving you a total score of 30 over here. 30 to 29 is considered normal over here. Borderline cognitive dysfunction if the score is between 28 to 26. And if there is a marked cognitive dysfunction, the score is between 25 to 18. And if it is less than 17, there is a severe cognitive difficulty or a significant dysfunction that the patient is suffering from. This is how you analyze the patient. It's a 5-minute exam that you can carry out initially, and that will give you a fair idea about the cognitive ability of this particular patient whom we are dealing with. The assessment of the suicidal risk is again very important over here. You focus on the facts and you even examine these patients in detail over here. You look for those tentative, hesitational cuts, the thought content, the thought form, the overall depressive state of the individual. But sometimes even the depressive state is not present in individuals who can commit suicide. So that can be quite a confusional state, and that can basically distract you as an examiner. So the assessment of the suicidal risk is even taken care of over here. The detained person's medical form is very important. You completely read that form and you look for the traits of suicidal intention in that particular form. It can be self-neglect, it can be depressive episodes, even it can be the manic episodes on the other hand. The general principles is the risk factors that we're going to consider over here in this particular assessment. So the risk factors can be the demographic factors that one can be dealing. It can be the male sex of the individual. Sometimes, usually, basically, the male population is more prone to the development of the suicidal intent or the suicidal thoughts. Then younger age is another risk factor over here, and even the single status is one of the factors over here. Living alone is one of the factor. So these are the demographic factors. These cannot be changed quite oftenly. Obviously, you can work on them, but sometimes these are basically the irreversible things or things that cannot be worked on. Then we have the history. History has to be taken in detail to figure out the suicidal intentions or the suicidal thoughts in this particular individual. Previous suicidal behavior is important over here, and if he or she has been admitted to some sort of a hospital due to a suicidal attempt, that is highlighted. Short duration of mental illness and severe hospital admissions or admissions within the last year. They are basically pointing out towards the depressive episodes in the individual. The recent change in the chronic illness is very important. And you're going to note down the substance misuse, substance intoxications are important. Then you carry out the mental state examination and you highlight the factors whether the patient is suffering from a depressive mode or not. Feelings of hopelessness, so that would be basically highlighted when the person speaks. The speech and the speech content is going to highlight a lot of factors over here, and even the hopelessness or the depressive thoughts are going to be evident in the speech of the individual. Psychosis, even it can be mania, as I was already focusing on the fact and telling you that even sometimes people who have these suicidal intentions, they might not be suffering from depression. Sometimes they are in a state of mania, and even that is highlighting the fact that they have suicidal intentions. So careful examination and listening to the speech of the individual is very important. Suicidal thoughts are going to be noted down in the speech, and the communication of the suicidal intent is again very important. Suicidal content to psychotic phenomena. So it's again very important that how the person is relating different sub-objects, different people to this particular thing that he might be planning on. Other factors are specific to the police custodial environment. It can be the nature of offense is very important. So you note down what kind of an offense the person has been into. That is going to highlight these facts, the feelings of guilt associated with the offense that he or she has committed. First time in custody. So sometimes people who go first time in the custody, they go into a depressive state. This depressive episode is severe enough that they can cause suicidal intentions or suicidal thoughts for these individuals. Early hours of detention is again very important, as people who have been put to detention in the early hours usually suffer from these kind of thoughts. Alcohol, drug intoxication, and withdrawal effects usually give you these suicidal thoughts and suicidal intentions. Now, assessing an episode of self-harm in custody. So you would come across a lot of patients who would have these feelings of self-harm, or they have committed some sort of tentational cuts, or they have committed some sort of hesitational cuts, and they would be brought up to you. When you assess these patients, it's again very important to mark these patients having the suicidal intent, because these hesitational cuts and tentative cuts can basically highlight the fact that the person has traits of self-harm. And that is very important that you highlight that in your documentation that you're going to carry out, because that assessment is very critical over here. Now, the associated factors with that incident, you have to manage that over here. A medically serious act of deliberate self-harm. What is DCH? It's basically DSH is the deliberate self-harm that the person has. As you can even see over here, a wrist or the forearm, that is basically showing the tentative cuts. Multiple cuts, as I was already focusing on. Accessible part of the body. And these are the features of the tentative or the hesitational cuts. Writing a suicidal note is very important, and sometimes you would find that in the cell. The precautions taken against are found, and stated wish to die. So if the person says that he wishes to die, that is again noted down, and it is considered to be very significant. Belief that the act would have proved fatal. So this is important, that the act is serious enough that it can prove fatal, and the person knows that. So it is basically proving the fact that he or she wants to commit suicide. Expressed regret that the act failed. So even after the suicidal attempt, when you'd be interviewing this particular patient, that is going to highlight the fact that he has no regrets towards it, that he committed this kind of an act, and he would in fact regret the fact that he's alive or she's alive. So this is the suicidal intention, and this would be the type of thoughts and the thought content that the patient would be having. Then again, we have the previous episodes of deliberate self-harm. We have depression and psychosis the patient is suffering from. Cases of drug intoxication are usually brought to you. Cases of any comorbid psychotic conditions, comorbid psychiatric conditions, for instance, schizophrenia, OCDs. And then we have the impulsive and the aggressive personality traits, type A personalities or borderline personalities. That would be even highlighted. Loneliness and the lack of a social network. Having less friends, having less relatives around, close relatives around, is again one of the key factor over here, leading a person towards the suicidal intentions or towards the suicidal thoughts over here. So, when you are working as a forensic practitioner, you must know how to basically sum this criteria up. You would be dealing with manias, you would be dealing with bipolar disorders, schizophrenias, and you must know how to diagnose these cases in the detainees, in the commission cells, and you must know how to treat these cases in a proper way. So, that is the end to the lecture. Thank you for watching sqadia.com.